In Australia, we have palliative care processes in place for people with dementia in nursing homes. And we also have another model that we use, which is called case conference. Now, case conference is something that we usually use routinely when the person is going into some sort of crisis state, or the management of that person is not going as well as we would like, or we need more information from the families and the GP to actually improve the care that's being delivered. Now, what we found is that people are using case conference in situations of crisis rather than using it routinely. And because we know that our work in the person-centred model has been very effective in helping people to know how to care for someone with dementia in a much better way, with much better outcomes, we decided to combine the person-centred model in the case conference. And to do that, we trained up nurses in the aged care facilities using a palliative approach, using a case conference approach, but from a person-centred approach. And what we did was to train them up in this model. We got them to facilitate case conferences regularly for people at the end of life with dementia, and to actually include the families, to include the person with dementia, to include the GPs and all the staff, including direct care workers and social workers, and to bring them together to have a case conference on a regular basis. And the focus of that case conference was not just about medical management, it was about what can we do to improve the quality of life, to improve the well-being, to improve symptom management for the person, but using psychosocial approaches as well as medical treatments. That was what we tried. We did it under a cluster randomised trial approach, and what we found was that there were some good effects in terms of symptom management, good effects in terms of quality of life, and good effects in terms of training the direct care staff and the nurses how to use a palliative approach to care. So generally speaking, it was quite a good effect. The effects weren't very large, but they were particularly good for people with many comorbidities. So when we have people there with chronic obstructive airways disease, heart disease, blood pressure problems, arthritis, maybe even cancer, these people seem to do particularly well with this model, because instead of just focusing on medical treatment, we also focused on the psychosocial needs of that person. What we now know is that the facilitated case conference model is effective if we run it in the way that we ran it, which is from a person-centred approach. And that is inclusive of everybody involved in the care of that person, including the family. So we will continue that, and we'll go to government to actually explain that in the policy that we have around case conference, this is a much better approach to use. The other model is that the palliative care model, which has been used in many aged care facilities, we now know that that model needs to be used for all people with dementia. So that rather than just focusing on doing care and giving treatment, what we need to do is focus on palliation. So anybody who comes into the nursing home with dementia needs to go through this process of palliation, because that really addresses their psychosocial needs as well as their symptom needs.